everyone. Welcome to today's CalMap webinar on autism spectrum disorders as they present in early childhood with a focus on preschool to elementary school ages. We're so glad you're able to join us today. I have the privilege of introducing our speakers for today. Dr. Christie Enjey is a clinical psychologist and associate clinical professor at the Center for Autism Center Disorders and Neurodevelopmental Disorders in the UCSF Department of Psychiatry and Behavioral Sciences. She has specialty training in behavior analysis and is board-certified behavior analyst at the doctoral level. Her specialty area is in the evaluation and treatment of youth with autism and related neurodevelopmental conditions. Her clinical and research interests are in applying and developing evidence-based treatments for youth with autism to treat core symptoms and co-occurring anxiety conditions. Her treatment approaches include cognitive behavioral therapy and behavior therapy, including naturalistic developmental behavior interventions based on the principles of applied behavioral analysis. We also have with us today Dr. Cory Patrick, who is a child and adolescent psychiatrist for the Division of Child and Adolescent Psychiatry, the UCSF Department of Psychiatry and Behavioral Sciences. Dr. Patrick is currently serving as medical director of the UCSF Autism Spectrum Disorder and Neurodevelopmental Disorders Clinic, and he provides a majority of his clinical care through the Center for ASD and DTs. He treats a variety of conditions, including anxiety disorder, OCD, mood disorders, impulse control disorders, and irritability aggression in the autism spectrum disorder. Dr. Patrick continues to have a passion for genomic medicine and is a champion for smooth incorporation of diagnostic and pharmacogenetic testing. If we can move on to the next slide, just a quick note on our funders and acknowledgement to our funders, including HRSA and the California Department of Healthcare Services, specifically their Child Youth Behavioral Health Initiative. As usual, we will be reserving the last 10 to 15 minutes for audience Q&A. So if you have any questions for our speakers, please type them into the Q&A portion of the Zoom controls here. And with that, I will hand the virtual mic over to Dr. Lin.
Okay, hi everybody. I'll get us started, and after I present, Dr. Patrick will present. So our learning objectives are to identify signs and symptoms of autism in young children, identify first-line treatments for young children with autism, including common psychiatric comorbidities, and identify 3 paths by which parents can obtain resources for young children with autism. First, we'll start off with diagnosis. Just to review these diagnostic criteria for autism, many of you are already familiar with it, but we can go into a little bit more nuances about these in the upcoming slides. But one of the areas that children need to meet criteria is this area of deficits in social communication and social interaction. And this means difficulties with social emotional reciprocity. So an example could be maintaining play and conversation with others. The other area is nonverbal communication differences. So not only integrated eye gaze, but things like a range of facial expressions that they use and direct to other people. And then the other area under this umbrella is developing, maintaining, and understanding relationships. A specific example other than friendships could be provides and follows the play ideas of other people. Then you also have these restricted and repetitive behaviors, interests and activities, as well as sensory differences. So what we look for are some behaviors such as stereotyped or repetitive movements, use of objects, and speech as well. So this could be repeats phrases that they heard from other people. There could also be insistence on sameness behaviors. That's being really inflexible with how routines are completed, or even they might insist on ritualized ways of doing things, like an elaborate ritual for bath time. And then highly restricted interests such as numbers, or hyper or hyposensitivities like visual peering. We'll go into more details about these things in the upcoming slides so that we can help maybe provide some nuances for some things to look for. Next slide. So in terms of early concerns, what pediatricians are likely to see in young kids to help them think about, oh, I have concerns for autism. One of the primary things that come up for very young kids is actually language and social communication. Either not speaking or having a very limited vocabulary is one of the red flags for autism, but we also want to look for communicative intent. It's not just are they speaking, but what are they speaking about, or how are they speaking? Are they making only requests, or does this child not speak at all? But also, are they talking just to be social? That's the important piece. One of the distinctions of autism is that kids are speaking to requests, but they may not be speaking as much to connect with other people, like making some kind of noises to make comments, or to connect with people in a social way. We also want to look for gestures. That's part of social communication, like waving goodbye. But we also start to see at this young age early social concerns, and that's interest in people, watching them, seeing what they're doing, imitating on their own the actions of people around them, as well as being responsive and trying to maintain playful interactions. They are trying to smile and look and engage and have shared enjoyment with the people around them. But we're also looking to see, are they starting and responding to attempts to get their attention, and they're trying to keep it up. They're being playful back to keep those interactions going. So those are some of the things we want to look for in these young kids. Next slide. From 12 months to about preschool, we're looking at other kinds of behaviors. We're looking to see, are there increased behavioral concerns, particularly behavioral concerns that limit and interfere with social engagement. Around 12 months to preschool, there are many behavioral concerns that come up for many kids of this age. And so you're looking to see how much are those behaviors interfering with social engagement. You start to see in kids with autism significantly more emotional dysregulation for things that other kids also get upset about, but it's like the heightened emotion regulation difficulties. Maybe it's more severe. So you might see kids who line up toys, insist things are played or done a certain way. They might over-focus on parts of toys or objects. You might start to see some more of these repetitive motor mannerisms that are not decreasing with development, but seeming to stay maintaining as they're getting older. And then you might also see these sensory seeking behaviors, putting objects to their cheek to feel them. And so you're starting to just see that these things are not decreasing as kids are getting older, and you're seeing that they're interfering with their interactions. And then on this age range, you're starting to see general interest in interactions with peers. They seek their peers out. They're watching them. They want to join them, maybe not for sustained periods of time, but they're doing it more and more every single year. They want to join groups of kids and what they're doing, and they're showing shared enjoyment with these kids as well. Next slide. Then some things to look for in these elementary school age years are that what we want to start to see is kids developing closer selective friendships as they progress through the grades. So when they're younger, you see all the kids playing together and they like to play and be active. And then as each year goes by, they're forming more selective friendships. And kids with autism, especially those who have more abilities, they're really showing difficulties with this, that they're not forming as many selective friendships. You also see special interests can become even more prominent. They're researching information. They're talking about topics at length, about different kinds of things that they're interested in that maybe other kids are interested in too, but they go way deeper, like outer space. They also insist on and show emotional activity to changes to preferred routines and expectations. Like we said, like this elaborate bedtime, elaborate ways of doing things, or really strong reactions to little minor changes that, you expect to decrease in these school age years, but they're not decreasing. And you also start to see more challenges with reciprocal conversation. They're not building on social conversation. This is what we see a lot of in these elementary school age years. It's not about just playing actively with others. It's about having conversations and learning about one another's lives and, being there for their friends, and they're having trouble with this part. And you also start to see psychiatric conditions emerge in these school age years. Next slide. So some of the things, some kids can seem very clear in the office of having autism, but the kids who are often tricky are those kids that have some language. They are the kids we often see getting diagnosed later on in life. We forget, but many children who have autism have average to higher IQ as well. And they are verbal too. And so, what you want to look for across your visits with kids, if you have a suspicion, or parents have a suspicion, or somebody in their life has suspicion about autism, what you're looking for is, do they have a back and forth way of interacting with you? Even kids with simple language, like a 2 or 3-year-old, they can show reciprocity. And so, you're looking for, are they building on what you say and do, especially if you've seen them several times? Are they sharing what they did? Are they interested in what the things you bring up? That's a big key thing to look for. What we see with kids who have autism, who have more abilities, they initiate a lot, but it could almost seem one-sided. And so you want to look for, well, are they interested in me too? Um, and so if you feel like you're doing all the work, you're having to be the listener. Also, maybe they only answer direct questions or they don't readily share about their experiences. Or they only interact with you to ask you about specific things. Like yesterday, I had a kid who kept asking me what kind of shifter I had in my car, and asked many people that. It became pretty clear he was initiating with me only for a preoccupation rather than really wanting to know me. And so these kinds of things can help you realize, hey, this kid is speaking and probably is grade level with their academic abilities and cognitive abilities, but they're having difficulty connecting socially. Next slide. The other thing to consider that can be tricky are girls. The diagnostic criteria still applies to girls with autism, but they are showing milder social and social communication differences. Some evidence is showing that the frequency to which they interact, like make initiations and respond, it's similar to the rate of typically developing boys and typically developing girls. And so that's why often girls are underdiagnosed or overlooked. They are doing these things, but the frequency isn't matching that of their peers. They show social interest, they imitate, they have imaginary play, but their response to bids are lower in frequency. As I said, and maybe the quality is also off. They're a little bit misaligned with what's happening in the social situation. You see this limited reciprocity and self-directed nature, especially when there's no structure in the environment. There's not explicit ways or things they're supposed to do. They tend to be a little bit more self-directed and a little bit more less initiating because those expectations of how to be are missing. Um, what's common that shows up is that there are milder restricted repetitive behaviors. They are still there, but they are milder, so you have to really look for them. And their special interests are related to what other girls really like too. They might really be into princesses, but the intensity to which they're interested in these things are higher, and really it's limiting them. They're not able to pivot and add, other interests the way that another typical girl would be able to do. What we also see is they are socially interested, but they have poor skills to maintain friendships and they're left out by other girls. They're accepted, but they're not sought after. And so what you start to see with these school-age girls who are not diagnosed yet is that they don't have as many meaningful friendships. And so that's kind of a red flag for you if you notice that and parents are saying that. And they often receive a later diagnosis because the social demands are becoming more advanced. So we see them in adolescence or later. Next slide. Something else that we want to keep in mind are these repetitive restricted behaviors and sensory differences. So repetitive behaviors, sensory differences, we see them across development and we see them across psychiatric conditions. Having RRBs, or restricted repetitive behaviors, and sensory difference, they're not specific only to autism. It's that constellation of everything that makes a diagnosis. But what the research does show is that these sensory differences and the RRBs, they more negatively impact people's functioning in autism than any other category, any other neurodevelopmental delay, or any other psychiatric condition. So that's something to keep in mind. If you're like, oh, I see this, but it's really interfering, that's when it's like a red flag. Oh, this might be autism actually, and it might not be anxiety or this other thing, but actually might be autism. And in terms of sensory differences, we see sensory sensitivity to across diagnoses, but sensory seeking behavior seems to be a little more specific for autism. So that's peering at objects, maybe seeking out sensations like sniffing objects, putting things to their faces and exploring them. Those things seem to start to differentiate autism a little more. So these are things to keep in mind when you see kids in your clinic. Next slide. There are different forms of RRBs, and this is helpful because we often think about these lower order RRBs that show up in early development. We're talking about repetitive motor mannerisms like hand flapping, fixating on parts of toys, like instead of playing with the whole toy car, they're fixating on the wheel, or not playing with toys as they are intended. They're not using them in functional ways. For example, they might be holding toys, but not really playing with them, or they might be, just not playing with them the way they're meant to be. But you want to also think about these higher order behaviors, and they occur in later development, preschool and on. And we see things like insistence on sameness. For example, I had a kid who the bathtubs and the bath toys had to all be put in the toy in a very specific way. And if not, the child would get really upset. So it would be a long bath time because each toy had to go in a particular kind of way, dive in a certain kind of way to be put into the bathtub. You also look for verbal rituals. This is where kids insist that they or other people say things in a very particular way. Example for this kid I just talked about, the parent had to always make the same comment every time at bath time, or the kid would insist on it. It's something the parent might have said several months ago, but they insist that the same thing be said in the same sequence. You also see these special interests like numbers, or like I said, something maybe even more specific like shifters of a car, or they're very stuck on certain routines. The morning routine has to be done the same way because that's how it was done, and it's really hard and very disrupting if it's not done in that exact way. So something to think about is like these higher order behaviors. Next slide. And a common question we get is, how do I know this is an RRB and not OCD? RRBs provide positive feelings. A child is seeking them out because they enjoy it, it's practical, it makes sense to them. But OCD is different because the emotional tone underneath it is fear or unwanted feelings. So they're doing these behaviors that are unwanted, undesired. They might even say, well, I don't even know why I'm doing this. I don't even want to do this. Or they feel very fearful, that they're scared if they don't do these things, something really bad would happen, or they look very distressed. And so we want to kind of figure out and find out with kids and parents, can you ask, are they doing it because they like to do it this way, or are they doing it because they're scared something might happen? And that's helpful to think about. I had a kid who kept getting images of Minecraft in their mind, but they found the images scary and they didn't like it. It was unwanted, versus another kid who really enjoyed these thoughts and images about Minecraft in their mind. So, the later kid, the latter example, the first example would be a kid who has more OCD, these recurring images that are very distressing. Um, Remember, both kids get upset. Kids with OCD and autism who have RRBs, they are both going to be upset if they cannot, do their ritualistic behaviors, but the reasons why they get upset are different. Next slide. Treatment. So I'm going to quickly go through treatment. Next slide. So one treatment that we do provide is ABA, Applied Behavior Analysis. And, I just want to clarify that ABA really is the science of learning, teaching, and examining what are adaptive behaviors that make me successful as I can be in my situation. It's applied, meaning it's meant to help improve the lives of people and animals. ABA is used for people and animals. It's used in all places. It's not just for therapy, but it's also used in schools, homes, and businesses. It's used across ages and needs. They're not just for problem behaviors. And they're used for all people, even your neurotypical people, as well as those who have autism or other kinds of neurodevelopmental conditions. Next. But ABA has been shown to be very helpful for kids who are neurodiverse. Anything behavioral has been shown to be helpful, and that's why behavioral therapy, applied behavior analysis, they all kind of fall under this umbrella of behavioralism, which is the studying of behaviors and how they are formed and how to change them. Behavioral therapy is a little bit more general. It's a broader approach, but they're still working on changing of behaviors, teaching new behaviors. ABA it goes into more detail. It's a little more systematic. I'm going to try this and collect information on how did that exact thing that I changed, how did that change the outcome of this person? So it's very detailed and very personalized. But they have shared goals. It is really about teaching behaviors that are going to be more helpful in a very explicit way. Next slide. What I want to help make sure everybody is aware of, there are two main types of ABA. We often think ABA is one type of treatment. It is, but there's different families. One is called discrete trial training, which was made as one of the original forms of treatment, where they treated kids who are very severely impacted because there were no treatments for autism or significant delays at that time. But people are realizing, hey, we have kids who have more abilities. We also have to keep in mind that we are also working with younger populations. So what do we do with that? That's how naturalistic developmental behavior interventions came about. That's short for NDBIs. And there are many different types, but maybe the most three common ones would be something like Project Impact, Early Start Denver model, and Pivotal Response Treatment. The first two maybe go up for younger kids up to 6, but PRT and these just naturalistic principles, they apply to people of all ages. Next slide. So NDBIs incorporate these behavioral approaches, but they also incorporate these new developmental approaches. How do kids learn? How do you teach them? It's not these strict trials of learning, but more how do we include a child's interest? How do you include teaching in a context of play? And that's what NDBI does. It takes those behavioral foundations and then kind of overlays it with understanding of children and how they learn. So it really teaches in playful ways, in play activities and daily routines around the home. Next slide. Example would be that I could give to you is if you're trying to teach a child who doesn't speak how to say the word nose. In discrete trial, you would sit a child across the table, show a flashcard of the nose 10 times, and if they said no successfully, you would tickle them or give them a Cheerio. It's very structured, maybe helpful for kids who really, really need any kind of distractions eliminated from their environment to focus on what's salient. Another way NDBI would teach this would be you would figure out what is this kid motivated for and how can I incorporate this teaching in play in their daily routines. Again, maybe you're trying to teach this kid nose. You know that they like to go to the playground. So you're going to say nose. And if they make an attempt to say nose, you're going to put sunblock on their nose and then go out to the playground. You're doing less trials, but it's connected to their daily life. So it can be more meaningful and salient. So they learn that faster. And that's what some of the research has showed. And it's related to their daily routines and more naturalistic rather than so structured. Next slide. ABA has many different types of goals. Some of them are, like I said, it's not just for problem behaviors, but ABA can be used to help kids learn ways to enter and join social interactions, develop developmentally appropriate play behaviors, whether it's playing with themselves or other people, teaching adaptive behaviors instead of using problem behaviors, instead of being aggressive, what's the function behind that behavior, and how can we help them learn replacement behaviors. Then they also teach daily living skills and then using communication for social purposes like conversation. I'm going to be wrapping up soon. Next slide. Here's a little tidbit just to give you, ways to coach parents when they come into your office. We know that we're waiting for services for a lot of families, but giving them even one little way to help make an improvement with their kids means so much while they're waiting for services. So this is taken from Project Impact. I'm just going to quickly go through some of these so that you could learn how to use this and give this golden nugget to your patients. First, what you want to do for kids who do have some play and language skills is you want to instruct parents to join their child's play. It's like a conversation. You want to go with what the conversation's about. So in this case example I'm going to give you is a kid who wants to put all their toy dinosaurs in a toy train. Second, the parent is going to copy their child's play ideas. Third, they're going to look for a situation that the child needs them in play. So maybe the parent is about to put that last dinosaur in the train to start the train ride. That kid's going to be really looking at that parent, have the parents really have that attention of their parent because they want that dinosaur to go into the train. But at this moment, the parent's going to share a prompt to play. And it could be a prompt of a new action, like, hey, the dinosaur needs a book for this ride. It could be a statement, I wonder what the dinosaur needs to pack. And then if the child follows through and gets a book or something like that, giving it to the dinosaur, then the child has actually expanded their play, and the parent will then resume the child's play. They'll just put the toy dinosaur into the train with the book, and they kind of continue on with the child's play idea, basically reinforcing this child. Next slide. Next slide. There we go. So these are prompts for expanding play. You always start with the least supportive to the most supportive. You're going to give leading statements, make a comment as to what you'd like your child to do. If they don't follow that, the parent would ask a question like, hey, what should the dinosaur pack? Or what kind of book should we get? Then after that, if the child doesn't follow through, you give a choice. Hey, should they pack the red book or the blue book? If they don't respond to that, you give a verbal instruction. Get a book for the dinosaur. If they don't follow that, the parent's going to model the action. Get a book and put it in the dinosaur and the train. Or they, at the very end, is physical guidance, getting the book and actually helping the child put it into the train. Next slide. All right, there are additional treatments like I wanted to mention for CBT, especially for those kids with age level language and cognitive abilities. CBT can be treated for lots of different concerns, and there's more and more growing evidence that it's helpful for kids with autism. It could be used to treat anxiety, depression, emotion regulation, as well as social communication and social behaviors like social skills. And there are a lot of evidence-based social skills programs that actually draw upon CBT to help kids learn. There's a difference between social skills program and social groups. Social skills programs are actually really trying to help kids take the skills, learn them in the group, and then apply them outside of that situation. Social facilitation is more, we're helping kids play in that moment, but we're not actively coaching parents on what to do or actively giving homework or assignments for kids to apply these skills outside of that situation. So that's something to keep in mind. We want to make sure kids can have both types, but definitely having a social group where they're learning skills and parents are learning to coach their kids outside of these situations. So you got to think, what is my purpose? Next slide. Last, we wanted to just help you guys remind you about these provider resources. We don't have our social worker here today, but we do have a lot of resources on our CalMap website that can help you give support to your families. Next slide. There are many different ways to access services, evaluations, and treatments, the regional center, health insurance, the school district, and other benefits that are all listed in our website and that our care navigators can also help you with as well. Next slide. All right. So I'm going to hand it off to you, Dr. Patrick.
All right, thank you, Dr. Lin, for all the wisdom into diagnosis and therapeutic treatment. So for most of my presentation, we're going to kind of be operating under the framework of you have a child in your office who either have a really high suspicion for autism or they've already been diagnosed with autism. And we're going to talk a little bit about other recommendations around medical evaluation, as well as ways to distinguish between autism-related symptoms and other psychiatric comorbidities, and then treatment with the focus on medication management for those psychiatric comorbidities. Next slide. So for a child in your office who's recently been diagnosed with autism, there are a few different further medical evaluations that you should consider. So first one mentioned here is genetic testing, which is widely recommended by related professional societies in children with autism. And I'm specifically talking about diagnostic genetic testing here. So looking to see if there's a large effect size mutation, genetic disorder present that could be, at least in part, responsible for the development of autism. And benefits of identifying these include determining if there's kind of further medical workup that should be done to identify any highly prevalent co-occurring conditions. Can be helpful for parental understanding of what's going on with their child, as well as provide some prognostic information around both cognitive and physical development, as well as provide potential sources for further support or access to any sort of research resources. And on the next slide, we'll discuss a little bit more about specific testing. Other recommendations to think about is if there's motor delay, the American Academy of Pediatrics, this is where I'm kind of getting a lot of this information from their 2020 guidelines. They recommend screening for thyroid problems. Lead level testing recommendations around that can vary a lot by locality, state, even like county and city. In California, the DPH recommends screening for kids at 12 and 24 months if they're in publicly funded programs, including Medi-Cal. And then for all children, they recommend doing it if there are the child's at high risk, including if they are known to be living in a house built before 1978, or if there's other particular risk factors present. Then there are other situational recommendations based on the clinical presentation. So you can consider neuroimaging if there's atypical regression, meaning regression after the age of 24 months, if there's microcephaly, macrocephaly seizures, or an identified genetic disorder with intracranial manifestations or abnormalities on the neuroexam. Also consider an EEG if there's a concern for epilepsy or an identified genetic disorder with a high rate of epilepsy. Can consider metabolic testing if, once again, atypical regression, family history, or kind of characteristic dysmorphic features or comorbidities. And then with all these situational recommendations, definitely if you're seeing some of these features present, consider a referral to a specialist, including neurology, medical, or medical genetics. Next slide. So for diagnostic genetic testing, the recommendations are changing as we're learning a lot more about genetics and finding more ways to utilize that information. According to the AAP 2020 guidelines for a child with autism, they recommend starting with a CMA Fragile X, and then if those initial tests are negative, potentially moving on to whole exome, whole genome. More recently, publications from the College of Medical Genetics, as well as AAP in 2025, if there's intellectual disability or developmental delay with or without autism, they recommend starting with exome first. Exome can be a little bit more complicated to discuss with families, which is kind of an extra barrier there. So in that case, you may want to place a referral to medical genetics earlier. I know implementation has been a huge challenge here, even though this recommendation has been around for a while. Rates of testing are still, not where we want them to be. So some things to think about: referring to specialty clinics. Oftentimes, something to be aware of: a lot of the genetic testing companies, they also have genetic counseling services. Sometimes that patients can access, which can be helpful. And some of them even have like sliding scale coverage to help with any cost that's not covered by their insurance. Fortunately, insurance has been getting better about covering diagnostic genetic testing for these indications. Next slide. All right, now we'll shift to talking about psychiatric comorbidities. Next slide. And this kind of goes beyond just young children and school-aged children, but we've learned over the years that comorbidities are very common in kids with autism spectrum disorder. One of these disorders is present in the majority of children. The most common ones we see are ADHD, than anxiety disorders, but also a lot of other developmental conditions like learning disabilities, motor delays, and then intellectual disability. Next slide. But it's still, even though we know a lot of these disorders may be present, it can still be really challenging to distinguish what symptoms or behavioral presentations are due to kind of autism symptoms alone versus partially attributable to another comorbid condition. On this slide, I have a few examples of kind of overlapping symptoms and signs, and little cues about what may signal something is more related to autism or another disorder. I think a few different things that can be helpful to make this determination. So triggers and setting of when a particular behavior or symptom is occurring, the timeline or pervasiveness of a symptom, the process that is described by the child or parent around experiencing a symptom or behavior. And then I always like to look for, if I'm considering another psychiatric condition, whether or not there are kind of symptoms present that don't as clearly overlap with possible autism symptoms to kind of support an independent diagnosis for something else. So an example of where triggers and settings may be really helpful in determining the presence of another disorder is with anxiety. For example, if the child, especially with young children, a lot of the times what we're seeing or the presentation that's coming into the office is significant emotion dysregulation, which can be, of course, like very cross-diagnostic and due to a lot of things. But if a child is dysregulated in a very specific setting, such as being separated from parents, being left alone, or in anticipation of specific triggers for them, such as dogs, or even sensory triggers, such as like hand dryers is something that I've heard about. Even though it's a sensory trigger, if they're having a lot of like anticipatory anxiety around it, those are things that would suggest more of an anxiety disorder rather than just ASD symptoms alone. Whereas in contrast, if the dysregulation is kind of occurring in a way that's more reactionary, such as after the hand dryer goes off and they're responding to that and becoming dysregulated, or in reaction to an unexpected change rather than anticipation, that may suggest that it's more ASD related alone. An example of where timeline and pervasiveness of symptoms can be helpful is when we're thinking about mood disorders. So reduced affect and reduced social engagement can be present in both autism and mood disorders. With autism, we would expect those symptoms to have been kind of present throughout development to some degree, whereas with a mood disorder, we would expect parents to give us cues like, they did have a broader range of affect until, a few weeks ago or a few months ago, or there was some degree of like social withdrawal that happened somewhere along the way, potentially in response to a life event or a traumatic experience. Those can all be cues more towards a mood disorder rather than just ASD alone. And then process can also be really helpful. And I think particularly in young children, often getting information about process can be quite elusive because they're not always able to tell us. And even when they do have age-level verbal or cognitive skills, they may not quite have that level of insights or communication around emotions that allows them to give us clear insight into the process they're experiencing. And that can be particularly tricky with OCD, where they may not be able to articulate whether they're doing something because they want to or they feel like they have to, or talk about intrusive thoughts in a way that like an older kid may be able to. There can be, yeah. All right, let's move on to the next slide. So some other things that can contribute to diagnostic challenges are, you know, one thing that's very important in younger populations is kind of keeping the child's cognitive level in mind when you're thinking about normal behavior. You know, tantruming is normal to a degree in young children, and then progressively becomes less normal. But if a child is cognitively delayed, then those types of behaviors may last longer chronologically than otherwise expected. And then for our older kids who are verbal, other factors that can come into play are alexithymia, which is limited ability to understand their own emotional state, or kind of struggles reporting symptoms because of cognitive rigidity, or the way that they're interpreting questions in a very literal way. So sometimes it's helpful to kind of be adaptive in the way that you're asking the kids questions. Let's move on to the next slide. All right, and now we're going to move into kind of discussing treatment, particularly medication management for common disorders. But I think this is a good point to kind of step back whenever you're starting to think about using medications, especially in younger kids, to really take a few moments to conceptualize your case again, and review whether or not there's other medical things that you should be thinking about that could be contributing to the presentation, and really distinguishing in your mind what symptoms are related to autism versus another comorbid psychiatric disorder that you're going to try to target with medications. I think it can be really helpful to give parents some education around what you think will and what you think won't improve with medication management, and outline like what features of whatever is happening is more related to autism and should be kind of addressed through treatments like ABA or environmental modifications. And I think also creating clear expectations around medication response can improve parent satisfaction, can cue them into like really what they should be looking for when they're starting medications. And in long term, I've seen that has been helpful with compliance and getting patient buy-in. Next slide. All right, so I think kind of general rule of thumb when choosing medications for our various psychiatric disorders in kids with autism is that there's limited evidence supporting like diverging from our standard first-line medications in kids with autism. This is kind of beyond the scope of today, but there are some genetic disorders that where there's been specific studies into treating certain conditions within the context of that genetic disorder. So if you do treat a kid with a rare genetic disorder, I would recommend kind of like taking a brief look into that and seeing whether anything like that exists for that particular disorder. I think some common limitations, especially in young kids, is limitations around pill swallowing that may direct your medication choices, as well as ability to get labs and vitals to do the proper medication monitoring. And I will say with pill swallowing, I've had a good amount of success just checking in with parents and making sure that they've challenged their child recently around pill swallowing, because I've found a lot of the times, when I encourage them to challenge them again, and I provide them with a particular video online that helps coach using candy, that I've had some success there. And I've also found that using at-home lab services have been helpful in helping kids get their lab monitoring. All right, and we'll go into kind of specifics for each disorder fairly quickly, so we can get to questions. But for ADHD, first line is stimulants. Methylphenidates have been more studied in kids with ASD, I think we're particularly worried about, weight and appetite, especially if a child is a baseline picky eater. That can be a limiting factor that makes you move on to non-stimulants. And then the counseling is otherwise generally similar on average. The effect size for methylphenidates has been lower in studies looking at kids with ASD compared to neurotypical kids. Other options can include guanfacine and then atomoxetine. I think alpha agonists can be particularly attractive because a lot of kids with autism also have sleep disorders, and they can kind of treat both at the same time. Next slide. For management of anxiety, depression, and OCD in kids with autism, SSRIs are going to be first line here as well. And oftentimes if we're seeing emotion dysregulation, and with our younger kids especially don't necessarily end up meeting criteria, DSM criteria for specific disorders, due to difficulty kind of describing symptoms in a way that the DSM expects. So sometimes if you're seeing irritability or big emotion dysregulation, and there's a suspicion that anxiety may be at play, and these emotion regulation is interfering and clearly disabling, then an SSRI is often preferred to go to first prior to an antipsychotic. But SSRI is generally well tolerated in kids with autism. We definitely follow the edict of start low and go slow. And anecdotally, I've seen response from lower doses than expected in really little kids. And also found some benefits from splitting the dose in these really young kids to twice a day. And then after SSRIs, if they're not helpful or you're seeing a lot of side effects, there are a number of alternatives of them. Most of them haven't been extensively studied in young kids. Gabapentin is an exception that does have an approval for treatment of epilepsy. So at least there's like good safety data down to the age of 3 there. Next slide. Tic disorders are also something that often occur in the setting of ASD. I think with tic disorders, what's helpful to keep in mind is that, if they're not causing dysfunction, they're on the mild, moderate side, not painful, then they're not something that I would necessarily go to medications to treat, though there are some, if they are severe and disabling, haloperidol is approved down to the age of 3, though often we'll start with an alpha agonist first. Next slide. For treatment of insomnia, I already mentioned we'll often use alpha agonists, especially if there's co-occurring OCD, and then melatonin also has substantial evidence for treatment of insomnia in kids with ASD. Next slide. For treatment of irritability and aggression, I alluded to this before, that when there's, it's hard often in younger kids to identify the exact process, but as much as you can break that down, see if there's any co-occurring psychiatric condition that may be contributing to the irritability and aggression. The goal would be to treat that first, so that may be ADHD, so addressing it with ADHD medications or a component of anxiety where an SSRI may be helpful. If those medications are not effective or behaviors are really severe and dangerous, then you can consider going to second-generation antipsychotics, and Abilify and risperidone have the most evidence. With these, the goal would be to kind of start low once again, minimize dose exposure, make sure you're monitoring for adverse effects, and then also consider co-prescribing with metformin if anticipating long-term use. And there have been studies of metformin use in kids down to the age of 6. Next slide. Okay. And I also wanted to briefly touch today on folinic acid, which has been in the news a lot, and we've certainly been getting a lot of questions from parents about the use of folinic acid in kids with autism. So one point, so it's not currently FDA approved for treatment of autism or speech delay. There has been a recent movement towards getting an approval for a cerebral folate deficiency, which is a distinct condition, though there has been more research into trying to understand like how a similar process may be more broadly applicable to kids with autism spectrum disorder. And I think that the research there is still in process to understand where that line falls. There have been two single-site RCTs supporting the benefit. They had different primary endpoints, but supporting in one the benefit of folinic acid on language development in kids with ASD, and the other one had the CARS-2, which is one of our ASD diagnostic instruments as their primary endpoint. So it looked primarily at core ASD symptoms. Important to note about these trials, so they're relatively small with 40 and 80 kids roughly in each. In both, there was some prediction of response based on the presence of a folate autoantibody. They used high-dose folinic acid, so it is something that would need to be prescribed by providers. And overall, the benefits, even in these studies, while hopeful, they're fairly modest in terms of the improvement shown, though folinic acid seem to be fairly well tolerated. Important to note, though, that there has not been further validation by larger multi-center trials, and based on kind of the smaller numbers present in this study, that's definitely something that I would want prior to broadly considering these treatments. I think also similar to that the age ranges looked at in these studies were between the ages of like 2 and 14. One 3 to 14, I think the other one 2 to 10. And there wasn't all that much information about which kids seemed to benefit more and which kids didn't. So I think there's a lot of research in that area that would need to be done too, to if these benefits are seen in larger trials. The second question would be, are there particular subgroups that seem to benefit more than others? And I think folinic acid up to this point has mostly been used in the context of like known folate deficiency or chemotherapeutic agents that deplete folate. So there's not that much in terms of like long-term safety with high-dose folinic acid in kids who have potentially normal cerebral folate levels. So some limitations on safety data there. All right, I think that's it for today.
Wonderful. Thank you so much for this excellent talk. We've got a number of questions that have come up. Before we turn to those, I wonder if we could go ahead and just click through some of these next slides. We do have some resources that I want to point you to on our website that give you some tips for getting an autism evaluation. And also, if you've got specific questions, you can directly consult our psychiatrists and many psychologists, including Dr. Lin, for specific questions on autism. And this is information on how you can make those consultations either online or by telephone. And finally, you will be getting instructions for how to claim CME credit for today. We'll be coming to those at the very end. With that, I'm going to go ahead and turn to some questions. Can you comment on neurobiological differences that may underlie some of the behaviors that are observed in autistic children? This came with a comment. In my experience, describing behavior without linking to what's known about physiology can contribute to feelings of othering and ableism. So trying to give reasons, underlying physiological reasons, can often be helpful. Please comment.
Oh, sorry. Yeah, I think that's a really good question. And I think that generally, like when I get a question like that, I do kind of zoom out a little bit and talk about like the heterogeneous nature of autism. Um, I do talk about, there are a lot of different, um, probably a variety of differences neurobiologically that exist, as well as different kind of genetic changes that contribute to, in some settings, structural differences, but more commonly like cellular level differences in the brain. I think there's been some research into various different brain regions that may contribute more than others, um, including like cerebellar differences, which may, in part describe some of like the motor coordination um, disorders that we commonly see within ASD. Um, and yeah, but and anyone else have a good answer to that question at this point in time?
Yeah, maybe I just add, I think that one specific answer for something is it's really hard. I don't think the research is resoundingly showing that it's this particular pathway or these things, but maybe like general, it's hypotheses and gathering more information about these things. And so I think that more research is being done to understand kind of those underlying mechanisms or areas of the brain and body that are connected, but I don't know. I don't know if it's like resoundingly specific, if that makes sense, but I think it's a really good point for a future talk.
Wonderful. Moving on, there were some questions about leucovorin as a potential therapy. Can you please speak to that?
Yeah. So, sorry. Just so leucovorin, the generic name for that is folinic acid. So that's kind of what I was getting to at the end of the talk with that discussion. But it's not something that I have prescribed at this point in time. Though I think in individual patients who kind of closely resemble the patient population in those trials, it's something that I am open to having like detailed risk benefit discussions with families about. But I think that it's something that at this point in time I would not recommend widely to families.
Okay, thank you very much. And this might be for you, Dr. Lin. Can you please speak to evidence-based therapeutic approaches for autistic children that are not necessarily based in ABA principles? Is there anything in that space that would be considered evidence-based?
Um, I guess it depends on the age range for their child, but things like cognitive behavioral therapy for older kids has been shown to be helpful. There's even some research showing that CBT can be used to address core autism kinds of challenges, and so that's helpful. But there's a lot of research underway to really look at that. I think there's additional research being done to look at kind of relationship-based treatments for some of aspects of autism. And so I think there's just more research that needs to be explored. I think ABA is very helpful, ABA foundations for treatment to help build skills, but there are complexities with autism and different concerns that it looks like it needs like kind of like a multivariate approach to treat.
Thank you so much. I see a lot of open questions. Unfortunately, we will not have time to go through these all. Just very quickly, if we can move on to our last slide on claiming credit. We will be posting the recording as well as a PDF of the slides onto our website within the next week. But in the meanwhile, thank you so much for attending our webinar today. Thank you so much for our speakers, Drs. Patrick and Lynn, for this excellent talk today. And we hope to see you next month for our next webinar that will be coming up. And I believe this one will be on anxiety. Hope to see you then. And if you've got questions, please do type them into the Q&A portion or into the chat to help us so that we can address some of these questions for you. Dr. Patrick is typing a few answers here on transcranial magnetic stimulation. If you just like want to say something very quickly out loud before kind of
Oh,
close this webinar.
yeah. So I was going to say, so TMS is in terms of like treating autism, it is in more of like an experimental phase. Um, for TMS is approved, right, for treating certain comorbidities. And I think like one thing to look at in that case is to what degree patients with autism have been included in those trials. And I think that generally goes for kind of all of these medications. And I know at UCSF there is a study looking at TMS in treating adolescents for OCD, and that trial is including kids with autism. But even in kind of adolescents in general, TMS definitely needs to be studied a lot more.
Wonderful, thank you so much. We see some concerns about this website. We will investigate. Look for an email that will be coming to all attendees with full instructions. So, and I see another link coming in over here. So please do give this a try. But in the meanwhile, thank you so much for attending our webinar today. We hope to see you next month.